Okay, let's set the scene. You're a coding student, right? An operative report for a penetrating wound lands in front of you. We're talking a gunshot or maybe a stab wound. You're staring at it and your mind is racing. Where do I even start? Is this just a fancy stitch job or is it something more? If that feeling is familiar, trust me, you are in exactly the right place. So, here's our game plan. We're going to walk through this step by step to build up your confidence. First, we'll talk about why this is more than a simple stitch. Then we'll get into the real rules of exploration. We'll cover the red flags, so important, when you should not use these codes. After that, we'll learn how to pinpoint the right code by location. And to wrap it all up, I'm going to give you a keyword cheat sheet that'll turn you into a documentation detective. All right, first things first, let's really get our heads around the main challenge here. We need to move past thinking about basic wound repair and really unpack the coder's dilemma when these kinds of traumatic injuries show up. This, right here, is the million-dollar question you have to answer every single time you see a case involving penetrating trauma. Is it just a closure, or did the surgeon perform a true surgical exploration? The answer is always, always in the surgeon's documentation, and our job is to learn its language. Okay, let's get into the specifics, the real rules of the game. CPT codes 2010-100 through 2010-3. These are special. They're reserved for those penetrating traumatic injuries where the surgeon has to do a whole lot more than just sew up the skin. So what does CPT mean by a true surgical exploration? Well, it's not just a quick peek inside the wound. It's a full-on investigation. The surgeon has to physically enlarge the wound and then extend the dissection down into the deeper tissues. We're talking about the fascia and muscle. They're doing this to figure out the real extent of the damage, clean out any damaged tissue, and pull out any foreign objects. Think of this slide as your mental checklist. For you to even consider using one of these exploration codes, the doctor's notes have to paint this picture. You gotta ask yourself, did they document enlarging the wound? Did they mention dissecting deeper to see how far the injury went? Is there talk of debridement, removing foreign bodies, and tying off small blood vessels? If the op note ticks these boxes, you know you're on the right path. So we've talked about when to use these codes, but honestly, knowing when not to use them is just as critical for being an accurate coder. So let's look at the red flags and the common traps you need to avoid. This is absolutely crucial to understand. The exploration is often just the beginning of the story. If that exploration reveals a much bigger problem that needs a major surgery, like opening up the chest or repairing a major artery, then you do not use the exploration code. You code for that big, definitive procedure. The initial exploration is just considered part of the bigger job. It really all boils down to this choice right here. On one side, you've got your exploration codes for that deep, investigative surgical work. And on the other, you've got your standard repair codes for closures that don't need all those extra exploratory steps. It's one or the other, and the surgeon's documentation is what's going to tell you which road to take. Okay, so you've read the op report, you've confirmed it was a real deal exploration, and you've made sure no bigger procedure took over. Awesome, you've done the hard part. The final step is usually the most straightforward, just matching the code to the body part. And look how simple the code selection is. You can see it right here. 2010-100 is for the neck. 2010-01 is for the chest. 2010-02 covers the abdomen, flank, or back. And 2010-03 is for an arm or a leg. See? Once you've done the tough analytical work, this last part is just a simple matchup. And now for what I think is your most powerful tool. This is where we turn all this theory into real-world practice. Let's build your keyword cheat sheet so you can walk into any op report like a true documentation detective. I really want to land on this point because this is the golden rule. It all comes back to the story the surgeon tells in that operative report. Your job is never to guess, it's to find the evidence that's right there in black and white. The documentation is your source of truth, period. So what's the evidence you're looking for? Here it is. These are your keywords, your clues. When you're scanning that op note, hunt for these phrases. Enlarged wound, extended dissection, debrided to vitalized muscle. Seeing these words is like a giant neon sign pointing you straight to the 2010-100 to 2010-03 codes. If this kind of language is missing, you're almost certainly looking at a standard repair code instead. So there you have it, our deep dive into wound exploration codes. At the end of the day, remember that every operative report tells a story about what happened in that room. It's a story of assessment, of intervention, and of repair. The whole story is right there in the documentation.
The only question left is, are you ready to be its translator?